Hello everyone and welcome back to my channel. In today's video we're gonna cover about the anesthesia of propofol. Why do we use propofol so much in anesthesia and what do we have to be aware of? So to start, we're gonna start with the mechanism of action of propofol. Propofol has two main mechanisms of action. It's a GABA agonist and GABA potentiator. So GABA is the neurotransmitter in the body that kind of slow down in our SNS system. It's the opposite of glutamate. Glutamate, which is excitatory. GABA is inhibitory. So propofol is going to bind on the GABA receptor as an agonist, enhancing the activity of GABA. So by binding to GABA receptor, is going to increase the conductance of chloride and anion inside the cell, which is going to hyperpolarize the cell membrane, rendering them difficult for any excitation. So at the same time, it's also a GABA potentiator. So propofol, by binding to GABA, is going to decrease the dissociation of GABA from its receptor, so increasing the duration of GABA binding to its receptors. It's kind of close to the mechanism of action of ultra short acting barbiturate. I uploaded a video about it, thiopental versus methotrexate, and you can also watch that video. It has really great info, and I'm gonna try to refer, like comparing as I'm going, propofol with other drugs that we use or we used to use for induction in anesthesia, so we can have a better picture of why propofol is so much picked about among anesthesia providers. So now that we review the mechanism of action of propofol, what is the anesthesia profile of propofol? So propofol is an excellent amnesic, so it's gonna put your patient to sleep very fast. And also, because it has a short effect site equilibration, I'm gonna talk about this more when we get to the pharmacokinetic. It's an easily titrable drug. So it's easily titrable, that's why, and easily predictable. That's why we use that a lot in anesthesia. So it's gonna put your patient at sleep very fast. Propofol also decrease the incidence of post-op nausea and vomiting. Propofol also help with the sensation of pruritus, like the itchiness when you give like opioid during your no actual surgery. We know that opioid induces pruritus, so propofol is going to also help with that. Propofol also does not activate malignant hyperthermia like other drug like succinylcholine. Propofol does not release histamine like we saw last week with the thiopental and methotrexate. Propofol does not do that. Propofol has no effect on steroid synthesis like other induction drug like etomidate. Propofol does not have any effect on the fibrinolytic property when it comes to clot like ketamine. Ketamine inhibit the platelet aggregation. Propofol does not have any effect on our coagulation. Propofol does not induce any alteration in liver and renal function if you give it at short term. So it has a great anesthesia profile, and this is why it's largely used in anesthesia practice. So what is the pharmacokinetic of propofol? So propofol has a rapid effect site equilibration, just like methotrexate and thiopental. It gets to the brain like in like 30 seconds, and that's why your patient goes asleep very fast. So rapid effect site equilibration and the awakening rely on the redistribution when the drug leaves the CNS to the fat and skeletal muscle cell, just like methotrexate and thiopental. And so propofol also has a short context sensitive half time. So that means if you give an infusion of propofol for up to 8 hours, it's gonna take less than 40 minutes to have half of that drug clear out of the body. This is great. Unlike midazolam, it's a benzodiazepine that takes forever, or fentanyl, an opioid that has a very long content sensitivity, half time. So this is good, less than 40 minutes for infusion, up to 8 hours. This is a great profile that Propofol has. Also, Propofol is greatly metabolized by the liver through a series of glucuronidation and sulfation reactions, and is flow dependent. That means Propofol has a great extraction rate. I think it's greater than 90%, and it relies solely on the flow, the blood flow in the liver to get metabolized. So that being said, if you administer agent like H2 antagonists like cimetidine, ranitidine, they're going to decrease the flow to the liver, so decreasing the metabolism of propofol, so you're going to have longer effect on propofol. It's just something to keep in the mind. So propofol also has no evidence of accumulation if your patient has renal dysfunction and hepatic cirrhosis, even though it's greatly metabolized in the liver. Tissue uptake. Propofol is uptake uptake by the lungs, but when we come to the chemical property of propofol, we're going to see what helps with that uptakes in the lung. And also propofol has a rapid clearance. Like I said, is greatly metabolized by the liver, and its elimination half time is in between 30 to 1.5, 30 minutes to 1.5. That means if you give one time dose of propofol, it's going to take about 30 minutes or 90 minutes to see half of that dose eliminated in the body system, which also contribute to the fact that it's highly predictable and easily titrable. And the elimination, you can have 3% through the kidney, less than 3% on change in the kidneys. So why do we use propofol in anesthesia? The indication: we can use propofol for induction when you first want to put your patient asleep, so you can put that itchy tube in the mouth. Propofol is a great agent for that because it has a rapid onset because of its rapid site equilibration. We can also use that in total IV anesthesia infusion if you want to put your patient to sleep, not use any gas, just the IV propofol. You can do that. Propofol is also used in MAC cases. MAC cases is when you want your patient not asleep enough, awake to be able to keep his airway reflex, but not also too much awake. So it just like that middle case when you don't have to protect their airway, but also they are comfortable during the surgery. It happens usually during moderate to deep sedation. So you can also use propofol for those cases. You can use propofol for his antipyretic effect if you have used opioid for neuralgia technique and your patient develop like itchiness. You can use propofol for that, and it's also a great agent to prevent post-op nausea and vomiting at different doses. So we just have to keep in mind that propofol does not have an analgesia or muscle relaxant property, so you always want to supplement with short-acting opioid or benzodiazepine, just like midazolam. Propofol also can be used as a second-line agent for status epilepticus. I say second agent because it causes a lot of myoclonus, those rigidity in the muscle, and also apneas, a lot of apneas with propofol, although it does not induce seizures itself. So now let's talk about the physical property of propofol. Propofol contains the soybean oil, the soybean oil. The soybean oil decreases propofol first pass lung effect, and it's also helped with the emotion droplet size, because the bigger the droplet, the harder it's going to be to penetrate those tissue. So propofol has an adequate droplet size that makes him fast acting agent. So propofol also contains glycerol. Glycerol is there to help have the same tonicity with the blood, so it's isotonic with the blood. Propofol also have egg lecithin, so be aware of your patient that have hypersensitivity to white eggs, because propofol contains egg lecithin, and that egg lecithin is going to help to decrease the surface tension of propofol and help stabilize. Propofol also has benzyl alcohol, is kind of stop the bacterial growth of propofol. But once the bottle is open, or once you draw propofol in the syringe, that benzyl alcohol don't help that much. Reason why we have to use aseptic technique when we draw propofol, and after 6 hours we have to discard propofol because of the high potential of bacterial contamination. And we also have to change the IV line every 12 hours. Propofol has a shelf life when it's not open yet to up to 2 years, which is good. Now that we saw the physical property of propofol, what about the effect of propofol on each system in our body? So let's start with the CNS system. So propofol is going to decrease your oxygen demand, your cerebral oxygen demand, so which is a good thing, right? And I think that's also why it helps with status epilepticus. It's also going to decrease your ICP. It's also going to decrease your intraocular pressure. And this is a great agent for laparoscopic surgery, because in those kind of surgery, they tend to increase your IOP pressure. But propofol is great because it's going to decrease that intraocular pressure and decrease in the overall cerebral activity. So if you have your patient hooked up to the BIS monitor and you have propofol going at adequate doses, you might not see any tracing. So propofol on the cardiovascular system, it doesn't have any effect on the SA node, AV node, or let's say your patient who has Wolff Parkinson syndrome. It's not going to affect the conduction, but it's going to decrease your cardiac contractility. So if you have a patient with a low ejection fraction already, you don't want to give propofol. You can give other induction agent like etominate. I'm gonna make another video talking about etominate, but propofol is not gonna be the agent you want to go for if you have a patient with a low ejection fraction. Propofol is also gonna decrease your preload more than it decreases your afterload, so be aware of orthostatic hypotension. And you also want your patient to be adequately hydrated before you start your infusion of propofol. So when you first start your infusion with propofol, you're gonna have an increase in heart rate that is gonna be followed by a decrease in heart rate. So don't be alarmed. Oh, I started propofol, his heart rate is in the 200. What do I do? It's gonna come down. So also the risk of bradycardia related death is a profound bradycardia that propofol can induce, and that bradycardia can be even resistant to sympatholytic like atropine. So you really want to excuse me, you really want to watch out for your patient heart rate and stop propofol if that happens. So respiratory system wise, propofol is gonna decrease your respiratory drive, just like thiopental and methotrexate. And we have a great induction agent like ketamine. Ketamine will not affect your ventilatory like dose or other drugs, but with propofol, you really want to make sure your patient airway is secured. And this is the reason why even in ICU, we don't start infusion of propofol until the patient is on ET tube, because we want to secure the airways. With propofol, you have a dose-dependent decrease of your respiratory drive. So you want to make sure that your patient airway is secure before you even start propofol. So propofol also can cause post-induction apnea. It's rare, but it can happen after the induction with propofol. You can have some apnea, and that could increase the risk of aspiration. Propofol is a great agent for asthmatic patients because it causes bronchodilation. So if you have a patient who has asthma, it could be a great pick. And with hypoxic pulmonary ventilation, propofol does not affect it, just like nitrous oxide does. You don't see that hypoxic pulmonary ventilation depression with propofol. Now, on the liver or the kidneys, at short duration administration of propofol, you don't have any noxious effect on those two organ system. But if you prolong your infusion of propofol long term, you can see like a lot of fatty liver, rhabdomyolysis. But we're going to talk about it more when we go to the adverse effect of propofol. So, although propofol is a great agent, we have to be cautious, right? Because propofol has a lot of ingredient that people can be allergic to. So you want to make sure that you assess your patient allergies. You want to make sure that propofol has a great risk of abuse, just like barbiturate. So be aware of that. Propofol also can cause propofol infusion related syndrome. Like if you have given propofol for a long time, you can have things like lactic acidosis, rhabdomyolysis, fat liver. So you really want to monitor your ABG and stop propofol if that happens. Usually it's reversible after you stop propofol. So propofol has a high risk for contaminant bacterial growth. The reason why we want to use aseptic technique and discard after we have opened propofol bottle for more than 6 hours. Propofol also causes pain on the ejection site, just like we saw last week with barbiturate. But the pain is lessened, and we have other agents like etoposide that does not cause the pain on the injection site. But you can also give lidocaine before you administer propofol to decrease that incidence of pain at the injection site, but never mix lidocaine and propofol in the same syringe. If you accidentally give propofol in the arteries, it's not gonna have a bigger effect like we saw with barbiturate. Like they can cause necrosis or loss of the nerve. With propofol, you don't have that biggest of an issue. So the main interaction that I want to mention with propofol is that you never want to mix propofol with lidocaine, even though lidocaine is given like 1 minute ahead of time of propofol to decrease the pain on the injection site. But if you give them together, those emulsion of propofol, you're gonna like disturb the balance of this emotion, and it can cause embolization, and it also going to decrease the potency of propofol. Another agent like protamine is the reversal of your unfractionated heparin. So you don't want to mix them together as well because of the high rates of embolization. And there's also something I forget to mention about propofol, that we always want to shake it before we use it. And at the same time, if you have a bottle of Propofol and you see a lipid halo around, you want to discard it, because that's what they call crack, and it can cause a lot of embolization. So this is what I got for Propofol. If you have anything to add to this video, please drop a comment below. If you like this video, please like, share, subscribe, and don't forget to press the notification bell to receive my other video, and I will see you next.